Good. Hey, so kind of just real quick over, I know, has anybody looked at this stuff yet, or this is not even on your radar yet? You got other things you gotta crush first. It's coming there? Alright. Hey, so when we talk about the myeloproliferative stuff, right? All of these things kind of had this common mechanism in place. What was the mechanism behind them? Overproduction caused by mutation, which was resulting in what? All right, so you better be familiar with TKIs, tyrosine kinase, right? Tyrosine kinase inhibitors, the JAK2 kinase. Sound familiar-ish? So that JAK2 kinase, that mutation, which was that on switch, right? And depending on where that on switch is, will tell you what your problem set is. And this is kind of why I wanted to show you guys this. All right, so let's say the problem set with that JAK2 kinase was here with those pluripotential cells inside the bone marrow. What disease disorder were we talking about? Myelofibrosis, right? If that on switch is on here, right here, can everybody see where I'm talking to here? So if the on switch is here, and that JAK2 kinase is on, what disease disorder am I dealing with? I hear rumblings. If you're not getting that, right, you need to. If it's on here, this is the only cell line that's affected. That's essential thrombocythemia or essential thrombocytosis. Right? Depending on where that mutation takes place, it's going to tell you what disease disorder you're dealing with. Right? And we talked about, let's say your mutation is here. What are we looking at? If your mutation is all the way up here, what are we looking at? Polycythemia vera, right? Because PCV, all your cell lines are affected, but which one the most? Your RBCs, right? So if it takes place here, it's going to affect your RBCs, it's going to affect your platelets, and technically it's going to affect this cell line here, and your monoblast, just not the limbs, right? So just kind of understand, hey, what's the process? Because again, for this test, you're going to need to understand the pathophysiology behind the disease. You're going to need to know how this disease presents itself, right? And then basic management stuff. No, I'm not going to expect you to memorize 20 cancer drugs, right? That's not what we do, but just basic management. All right. That was myeloproliferative stuff, right? All right. Now let's jump into today's funness. If I can find it. Please work. All right, so that's coming on. So we've talked about the hematological malignancies. Does this sound familiar to anybody? All right. What's the hematological malignancies we've talked about so far? Leukemia, which comes in how many flavors of leukemia? Your 4. And what's the other malignancy we talked about? Lymphomas, right? And that came in how many flavors? 2 big flavors, right? And then we're going to end up talking today about something called multiple myeloma, right, under the plasma cell, and that's your other hematological malignancy. All right, so again, me, sports guy, 1904, no, I was not there. All right. Fred Lorz, this guy, wins the marathon. Yay, everybody's cheering, goes nuts, right? And then somebody points out that, hey, this dude just jumped out of a car. Right? So he ran the first 7 miles, got a little tired, so his coach said, hey, let me give you a ride the rest of the way. He gets a ride for the next 11 miles, jumped up like a mile from the finish line, and what do you know, he wins. Right? When something doesn't look right, there's a reason. Right? Don't trust anybody. All right, plasma cell dyscrasias. So the 3 diseases we're going to talk about. So think of this as sort of one disease, and we're talking about it on the continuum. Right? The initial pre-malignant stage is MGUS. Then it advances to something called smoldering, right? Which again is a pre-malignant stage till it gets to the plasma cell myeloma. otherwise known as multiple myeloma, which is the malignant process. Alright? Alright. So again, what are plasma cells? B lymphocytes. B lymphocytes that do what? Produce antibodies. I'm gonna talk monoclonal. Mono meaning what? One, right? So it's of that same one, that one type. Alright. So plasma cells produce antibodies, otherwise known as immunoglobulins, just globulins, and these are the flavors of immunoglobulins, right? IgM, big one. IgG is the most numerous, right? 80% of your in the serum is IgG. But you also have some IgA, IgE, and IgD, right? But from in terms of quantifying, IgG is a big player. That's the most common. So there's your structure. Right? Typical antibody structure. Right? The heavy chains, the light chains, and that's going to become important to you when we talk about testing and screening sometimes, because you can test for light chains. Right? You can test for heavy chains, and that's why those are going to matter. All right. Some terminology. Make sure we're all talking the same talk. Gamma globulins. Class of globulins identified by their position. So as we look at electrophoresis, and we'll pull up some charts here in a minute, right? We're talking about globulins, immunoglobulins, antibodies, whatever, that's occurring at a certain location when we talk about electrophoresis at the gamma location. And we see that in a second. Light chains, we talked about, right? Part of that component of the IgG or the IgM or whichever one, right? And they come in two flavors, kappa, lambda. And again, you can measure those in serum or urine. Heavy chain, we saw gammopathy, abnormal increase in immunoglobulins. And then monoclonal we talked about, right? Proliferation of a single type, whatever that type might be. Serum protein electrophoresis. Everybody familiar with electrophoresis? Right? Send a charge through it, travels through some gel, and it separates based on size and whatever other, electrical properties it may have. Serum or urine, and then light chain assays. Those are key terms and testing methodologies. Monoclonal, M protein. Monoclonal protein, yep, abnormal, we talked about, and either the immunoglobulin or the free light chain is what we're measuring. When they break these out, most frequent M protein, we'll talk about exactly what the M protein is in a second, it's IgG, occasionally IgA, IgM is possible, but you almost never see it. Right? In this case, IgG again is the key player. So this is what we're talking about when we talk about locations and sort of the electrophoresis. When this breaks out albumin, you see that huge spike. That's because the vast majority of the protein in our body is albumin, and that's why you get that huge albumin spike. Next, you have that alpha location, alpha 1. And you can go up here and see HDL and thyroid binding globulin and so forth. But these are the proteins that break out in the alpha 1 location. Here's your proteins that break out in alpha 2. Some that we may be familiar with, like haptoglobin and antithrombin 3. Right? Moving on to beta, you can see, hey, that's what's there. That gamma, right? Gamma location, which is key to what we're talking about today. You see your immunoglobulins, IgA, IgM, and IgG. Pay attention to that gamma location. So that is what normal looks like. And that is what abnormal looks like, a gammopathy. You have an abnormal increase in one of those immunoglobulins, right? It's monoclonal, so it's one of those immunoglobulins at that gamma location. right? So that's either increase in IgA, IgM, or IgG. Everybody tracking? I believe you. All right, plasma cell discrepancies.
So is that the production of the proteins from the plasma cell itself over the lifespan of that plasma cell?
Right, so that's what you're, that's a snapshot in time, right? So at that moment, you see that rapid increase. So again, that's what normal should look like, right? So here, this is telling me that I have an overproduction of one,
That's coming from the plasma cell.
from one plasma cell. So one type of plasma cell, right? So either IgG or IgM is being produced, IgA, that's causing that, right? All right, so dyscrasias. Group of disorders characterized by clonal proliferation of a plasma cell. These cells produce, right, antibodies, got it, but now they're producing these abnormal, at M, right, we call that M spike, at that huge spike at that gamma location, right, it's referred to as the M spike. These are the sort of the continuum of the disorder. Starts out as MGUS, transitions to smoldering, and then finally, if it gets to that malignant stage, it's the plasma cell myeloma or multiple myeloma. Plasma cell. 1% of all cancers, 10% of hematological malignancies. Median age, again, most of these malignancies, most of the cancers we talk about, right, older population. There were a couple we talked about, a bimodal age distribution. There's some we talked about young kids. I would pay attention to that, right? All right, plasma cell we talked about. So the B lymphocyte that produces antibodies to the plasma cell. Clinical presentation in these patients, often asymptomatic. Labs, monoclonal protein spike, that M spike that you see in that electrophoresis graph. Treatment, usually no specific treatment, and then this is what you're worried about, and we'll talk about this as we talk about each stage of the disorder. Early on, what you're doing is you're monitoring your patient. You want to see if they're transitioned into the malignant stage. Have they tipped over from an MGUS to a smoldering? Have they tipped over from a smoldering to a malignant, a multiple myeloma? So MGUS, monoclonal gammopathy of unknown significance. That's a mouthful, right? That's the first step, the step in the disorder. Asymptomatic proliferation of plasma cells, producing those M proteins, that M spike. It's a benign condition. Risk of progression to multiple myeloma is 1% a year. So if I got 170-odd-year-old men and women sitting in here, right, chances that one of them are going to progress on within a year. Cause, maybe genetics, maybe environmental, MGUS. Again, asymptomatic, often discovered incidentally. Things that would make you start to concern, right? And that switch start coming on in your brain. Age inappropriate bone loss. Unexplained proteinuria. Elevated protein. Hemolytic process, anemias. So all this stuff is kind of vague, right? But if I'm getting some bone loss, and we'll talk about why. And we say it's often asymptomatic, often an incidental finding. Again, this is a patient. You just got they're in for their routine physical. You got a UA on them. You got a chem panel on them. Your urine came back with a little bit more protein than you expected. You look at your chem panel and their protein's elevated. You just chalk it up to You start asking some questions, then you get some other labs, right? And every day you're gonna be faced with these kind of decisions. You're gonna draw some labs. Everybody walking in your door is gonna get some labs, and you're gonna get some findings that's a little bit off. Which ones do you chase, which ones you don't? Physical exam, unremarkable. Workup, electrophoresis, serum or urine, electrophoresis, free light chain assays. Diagnostic criteria, M protein, less than 3. Plasma cells in the bone marrow, less than 10%, and no end organ damage. And that's your MGUS. So protein less than 3, plasma cells less than 10, no end organ damage. No crab. We'll talk about the significance of crab as we transition. But again, just remember this acronym, right? Calcium elevation, renal dysfunction, anemia, bone lesions. And you'll see in a minute why they progress and these are the symptoms that they'll display. All right. Management. No treatment required. Monitor every 6 to 12 months. So in the MGUS stage, there's no treatment, you're just gonna monitor. Bring this patient back in 6 to 12 months, repeat their lab work, see if they're becoming symptomatic, see if their labs have changed. Okay. All right, so if this patient comes back to you, and now they're describing bone pain, fatigue, start having these B symptoms that we talk about, right? Lymphadenopathy, bleeding, neurological stuff, that's red flags. And then laboratory results. Am I seeing a change in their labs? Is their serum protein now greater than 3? Alright. So MGUS in a nutshell. All right. What's your protein? What does your bone marrow look like? What does your patient present like? Asymptomatic, MGUS, right? And then how are you gonna manage an MGUS patient? You're gonna bring them back in 6 to 12 months and check their stuff. All right, moving on from MGUS. MGUS is now transitioning, next stage, smoldering myeloma. Same deal, proliferation of plasma cells, yes. Pre-malignant condition, yes. Much higher risk, right? We said it with MGUS, you had a 1% chance of moving on to multiple myeloma. Your risk just went up tenfold, right? Now you got a 10% chance within the next 5 years. Symptoms, typically asymptomatic, but they might start showing some symptoms at this time. But typically asymptomatic. Diagnostic criteria. Think of this in relation to the MGUS. Your M protein is now what? Greater than 3, right? And plasma cells in the bone marrow are now 10 to 60. You can see the progression. But again, with smoldering, you still have no end organ damage. Workup, kind of the same. You get your electrophoresis, serum or urine, get some labs, bone marrow, and then imaging in this case if you're worried about the bone lesions. When we get into the multiple myeloma, you'll see what the bone lesions are talking about. What's crab? Calcium, renal. You guys are killing me. Anemia, bone lesions. All right. Management. Again, surveillance. You got it? Realize, hey, this patient's transitioned on. They've gone from MGUS to smoldering, but now instead of 6 months, you're, hey, 3 months, I might bring this patient back, right? So 3 to 6 months. So cut the time in half. Early treatment. Is there a decision, right? Hey, you know what? This is in your future, man. Badness is coming. We're just going to treat you now. We're not going to wait anymore. All right. Now we move on to plasma cell myeloma. So the smoldering myeloma, transitioning now to the truly malignant process. Malignant plasma cell proliferation, significant M protein, and organ damage. All right, again, how is this disease process different than the other two? pathogenesis, right? So bone marrow infiltration. You have all these plasma cells accumulate in the bone marrow. Starts to crowd out the other cells. So when we talk about the cytopenias, what are we talking about? So again, limited space in the bone marrow. I got it filled with all these plasma cells. What else can't be produced in significant numbers? What's it going to impact? Impact your RBCs. Now you start developing your anemia. Go back to your crab. You got anemia, right? And in some of these patients, what's the other cell line that could be affected? Platelets. Right? So some of these patients too will start to display some thrombocytopenia. Right? So they develop these cytopenias. As these plasma cells continue to grow and they start to infiltrate the bone marrow, you start seeing the bone marrow start to break down. Right? We'll show some images of some osteolytic lesions because it's breaking down the bone marrow. What might that result in your chemistry? Hypercalcemia, go back to your crab, right? Hypercalcemia, right? See where this is coming from. This excess renal dysfunction, hyperviscosity. So all this extra immunoglobulins, it's hard on your kidneys. Your kidneys has to filter all this stuff out, so your kidneys take a hit, right? Leads to your renal dysfunction, leads to your crab. Accumulation of monoclonal protein in the blood, yeah, got it, right? That's our electrophoresis stuff, and we see our proteins. Kind of understand the pathophysiology, what's happening here. Maybe? Bueller? Alright. So hey, this is actually a pretty good diagram of kind of what's going on. So to your left, you're looking at norm, right? I got some nice plasma cells doing this thing, which is what? To produce antibodies, right? Looking nice, normal, some nice RBCs. I got some platelets in there, all good. All right. On the right-hand side, you've made this transition to multiple myeloma. So I have a lot more plasma cells, and they're abnormal plasma cells, right? They don't look like these over here. And they're producing excess immunoglobulins. And you can see what happens, right? They start taking up all the room in the bone marrow, so now I have less RBCs on the right side. I have less platelets, so I develop those cytopenias we talked about, right? Which manifests itself as an anemia. I'm not producing as many RBCs. Or maybe some thrombocytopenia, and I start having some bleeding problems because I'm not producing as many platelets. And I have all this excess immunoglobulins that my kidneys are going to have to filter out, so my kidneys take a hit. All right. Type of cancer develops from the plasma cells, we said that. Anywhere in the bone marrow, sure. All right. Leads to the replacement of normal marrow. Cytopenias, everybody tracking how we get to the cytopenias. All right. Plasma cells crowding out the other cells in the bone marrow, producing less RBCs, less platelets, I get my cytopenias. Hypogammaglobulinemia. Talk to me about that for a second. What are we saying here? Low. Right, you have abnormal plasma cells. We say, hey, you get these huge spikes. So in general, you tend to see more. But again, they're abnormal plasma cells, so they might not be able to put out a lot of immunoglobulins. So sometimes you'll see a decrease. Osteolytic bone disease. Where's that coming from? So they're infiltrated the bone marrow and they're starting to see this bone marrow break down. Hypercalcemia. As I break down the bone, right, I release calcium into the bloodstream, so I get hypercalcemia, renal dysfunction we talked about. Presentation, sure, the cytopenias, right, so anemia, very common for them to become anemic. They're experiencing this bone pain from these lytic lesions, and you'll see what they look like, right, back, hips. They start developing these pathological fractures. Patients that you wouldn't suspect they should have a fracture, they don't have a mechanism of injury to suggest a fracture, and they have a fracture. And again, what's our age population we're talking about for this? right? So you're talking about old 60s, 70s, right? And now these people come in with a compression fracture, and you're like, well, where's that coming from? Right? They're having bone pain. You're just old. Right? Don't say that to your patient. Right? All right. Spinal cord compression due to pathological fractures. Kidney takes a hit from all this excess immunoglobulins, but also this high calcium in there. Infection, prone to infection. Why are they prone to infection? Yeah, so they're antibodies, right? Again, abnormal plasma cells producing abnormal antibodies, not as effective. And then hyperviscosity syndrome. All this excess immunoglobulins floating around the system, creating this hyperviscosity syndrome. Presentation. Hypercalcemia. How does a patient with hypercalcemia present? Here's some stone bone drum stuff, boss. All right, you guys can go home for today. You're done. Right, and that's it. Right. So early on, right, do they have the GI symptoms with hypercalcemia? Nausea, constipation, anorexia, right? Renal dysfunction. You get your elevated creatinine and your protein. Anemia, we beat to death, right? And then pain from your bone lesions, your crab. Excuse me. Anemia, pallor, bone tenderness. They have these lytic lesions. You push on them and it hurts like crazy. Soft tissue masses, right? Neurological signs, peripheral neuropathy, spinal cord compression, fever, and then signs of renal failure. All right, workup. And you get your bunch of labs, as we all do. All right, Mr. Smith, go to the laboratory and get some labs. Come back and see me in a week. All right, you expect to see some anemia, the normocytic anemia, renal function. Yep. And what are your renal labs? UN, creatinine, right? Protein, you'll see some protein, right? But you really want to see function, you get your BUN and your creatinine. What's your creatinine clearance? What's the patient's GFR? Calcium, we talked about hypercalcemia, so obviously elevated. And if you get some imaging on these patients, these osteolytic lesions. This is a patient that you've been watching and progressing and watching them go from NGUS to smolder. You're definitely getting your electrophoresis. But that's what makes your diagnosis for you in these patients. And if you get a bone marrow, you're more than 10, right? Probably more than 60. Diagnostic workup, continuing. Peripheral smear. Everybody familiar with rouleau formation? Stackings, right? The RBCs, they have all this excess immunoglobulin, so they're sticky, so they stack on one another. That's that rouleau formation. So you can see that here. This is not, hey, if I got rouleau formation, it means that my patient has multiple myeloma. There's other things that can cause it, right? But just understand, if you see that, then hey, some bells and whistles should be going off in your head. Right? And that's something on a peripheral smear. You get your manual diff, and good old lab tech, right? You're gonna note on their rouleau formation. Here we go. Oh. Alright, so this is your key. Hallmark. Alright, that M spike. So your serum, your urine, electrophoresis is key for diagnosing this disorder. Urine, talk about the 24-hour. Okay, so, and again, I have no lab techs in here. How did that happen? I'm never going to allow that to happen again. There needs to be one lab tech in every class. So when you do a urine dipstick, in this case, if I'm dealing with all this excess protein, do you expect that to be positive? You're saying, hey, protein urea. Truth of the matter is the urine dipstick measures albumin. So urine dipstick, this is not going to show up positive for, right? Because this is this Bence-Jones protein. And somewhere in your cranium, put that in the back of your head, because that's another thing you'll see on a PANS test, this Bence-Jones protein. And again, not detected by the urine distance, right? Because this is free light chains in the urine that creates these Bence-Jones proteins. So we talk about the kidneys taking a hit. Right? So all these free light chains, all this excess stuff, and this is just to kind of show you, hey, normally kidney can filter out whatever, 30. When you're dealing with plasma cell myeloma, that's how much it's increased that the kidney has to deal with, so the kidneys take a hit. Hypercalcemia, kidneys take a hit. You get this vasoconstriction within the kidneys, and then all this excess calcium deposits in the kidneys. So I got all this excess protein, this excess calcium, kidneys take a hit. Mulo formation, there it is. So that's like down to the whatever level, and that's what it looks like on a peripheral smear. Right? You just get this stacking of these RBCs. Again, all this excess immunoglobulins makes them clump together. Some more electrophoresis. What region is this? That's your gamma region, right? You can kind of see normal, yeah. Again, that M spike, that multiple myeloma, excess immunoglobulins in the gamma region. Some immunofixation, and this is just breaking them out, IgM, IgJ, your kappa, your lambda. You'll never have to interpret stuff like that. You got people in the lab to do that for you. You get a report back saying whatever. So, serum versus urine. Albumin being the majority of the protein in serum, you get that huge spike, which is normal. Multiple myeloma, that huge gamma spike, that huge M spike at the gamma region, not normal. All right, special diagnostic considerations. Free light chain, sure. Is it kappa, lambda? Bunch of ratios, got it. Excuse me. Essential for the diagnosis, so you gotta get a bone marrow, you gotta see what the plasma cells are doing. Is this kind of an MGUS patient? Is this a smoldering? Is this a multiple myeloma patient? Imaging, whole body, roof. I see no CT, PET scans, MRIs. Again, what we're looking for is those lytic lesions. So, I'm not a radiologist, but I ain't normal, right? You see stuff like that, that's the little lytic lesions, they're eating away at the bone marrow, right? These lytic lesions all up and down the vertebrae. Understand why these patients have bone pain. Spinal cord compression, why they can have some neuropathy and some neurological symptoms. You can see here in the cross section. Lytic lesions. PET scan, see lighten up. MRI, right? Not good. Right? Patient's having a bad day. That's pretty impressive. Again, understand why these lytic lesions, the hypercalcemia, that bone pain that your patient's complaining about. That might hurt. Understand why they get these pathological fractures. Right? It has to be a weakened bone. They just kind of trip and whatever, and boom, they have a fracture for something that wouldn't normally cause a fracture. Treatment, symptom control, yep. Chemo, immunotherapy, stem cell, and then you guys studied about the bisphosphonates. I know somebody took a guess. So bisphosphonates. And why the bisphosphonates? Oh no, sorry, I don't want to prevent. Right. Initial therapy, sure, some wonder drugs, right? Got it. Supportive. Bisphosphonates for bone disease. So I need to give them something to stimulate the kidneys, right, to produce some what? Erythropoietin, right, erythropoietin for people. And then that hyperviscosity, so I need to do a plasmapheresis to offload some of that. So that supportive care is important because this step up here, are we doing this? No, somebody smarter, bigger, stronger, better looking, makes a lot more money if we are doing that, right? But we might get stuck doing one of those. Outcomes. Median survival 5 to 7 years. Yeesh, not a great diagnosis. Right? And then complications. We talked about, hey, the infections. Renal failure, right? Because their kidneys are continuously taking a hit. Pathological fractures. I fall and I've broken my hip but I can't get up. Hypercalcemia. And all the things that go with it. So again, hey, there's just a kind of that acronym, CRAB. Hypercalcemia, so greater than 11. Renal insufficiency, kidneys taking a hit. I seen an elevation in your creatinine, your UA. Is there TFR taking a hit? Anemia, less than 10. Bone lesions, 1 or more, got it. And then the SLIM acronym to go along with it. These are the biomarkers. Clonal cells, more than 60. Because 10 to 60, I'm dealing with what? 10 to 60 plasma cells. Smoldering, right? Free light chain ratio, and then MRI showing movement. Crab, slim. More of the crab, slim type stuff. Right? Your differentiation here. So MGUS versus smoldering versus multiple. Right? Can you distinguish between the 3 disorders? I trust you can. And this is the disease in a nutshell, right? So what's going on? Hey, I got my plasma cells that's producing these abnormal immunoglobulins. And what's happening? I get my M spike in my gamma region, which again contributes to renal failure, contributes to the hyperviscosity. Don't worry about the amyloidosis, because I'm not. Immunodeficiency. What's causing the immunodeficiency? Abnormal immunoglobulins, right? So now I'm prone to infection, and now working upwards, yep, I'm attacking my bone marrow in the sense that, hey, all this is infiltrating out into the bone marrow. So I get bone marrow destruction, leads to bone pain and hypercalcemia. I'm crowding out my bone marrow, so I become anemic because I'm producing less RBCs. You can walk yourself through that and make sense of it. You're about 10% home. Good. All right. Again, we are the primary care. We are the workforces of the clinic. You guys know that, right? PAs are the workforces of the clinic. You're gonna go someplace if you're lucky and you're gonna grind. So I hope you like patient care, 20-minute appointment slots, except maybe Air Force, because you guys got like the space to read it. Like, you get it. Right? You guys know, like Air Force, right? You get out of here and then they like put them in a nice comfort someplace and say you got like an hour to see a patient for the first year, which is good, right? I wish I had that. Right. Again, I went to Camp Pendleton Family Practice straight out of here. And you're like, all right, you're brand new, you got 30 minutes to see a patient. The typical is 20-minute time slot, so I felt grateful that they gave me 30 minutes. Of course, by the time the corpsman checked them in, right, I'm already 15 minutes behind, right? Now you take that times 8 patients and see how far behind you are at the end of the day, right? And then you're spending your lunchtime doing this, trying to catch up on notes. Right? It was like all of that was Genesis, right? And then to make matters worse, at Camp Pendleton, they had a family practice residency. So the residents, who are no kidding like docs with all these years of experience, they get 45 minutes to see the same patients I'm seeing, right? Because they're residents, right? So again, I hope you like patient care. You know what you signed up for. All right. So hey, plasma cell. Again, it's a malignant process. Plasma cell myeloma or multiple myeloma. Think of this as a disease progression It's the same disorder, it's on the continuum. Starts out with your MGUS, transitions to smoldering, transitions to plasma cell myeloma. Be able to understand, based on your patient's lab, based on how they present, where do they fall on this continuum? And how are you gonna manage it?
So, when you're diagnosing the actual myeloma, is it bone marrow biopsy and then imaging, or is it imaging and biopsy?
So, somewhere in the scheme of things, like early on, it depends on when you get this patient. Did you receive this patient when they were in the smoldering phase, or you got it now, when this patient first came to you, they're already in the multiple myeloma phase, right? Because somebody never caught that their protein was going up all along, right? So this patient's been allowed to progress, or this patient was one of these people, it's fine, it's just back pain, I don't need to see anybody. So when did you get this patient, right? If you got them early on and you suspected it early on, you're gonna start the whole 9 yards. Because what you wanna do is be able to watch them, right? So you're gonna get imaging. At the same time I'm getting the imaging, I'm probably gonna order the bone marrow. Right? If I see lesions on there, and all the labs are pointing to this, I need to know where they are in the disease process, right? How do you make the definitive diagnosis on this? Bone marrow, right? And then what's the other big test here? Your electrophoresis. So it's not necessarily I get one before the other, right? But the imaging is easy. Hey, go down to the lab, schedule your CT, schedule your MRI. Doesn't really hurt the patient, right? Especially when I do an MRI, I'm not exposed them to radiation, low risk. Bone marrow, hey sir, this is gonna suck for you, right? So just kind of understand. It's easy to get some imaging and say, oh crap, I got some lytic lesions on here. But again, these are the patients that you're bringing back, right? So it's MGUS, I'm bringing back 6 to 12 months. It's smoldering, I'm bringing back 3 to 6 months. I'm gonna repeat my labs, repeat my imaging. Right? And if it looks like he's progressing, I'm gonna repeat my bone marrow to see where they're at. Does that kind of answer your question? All right, so again, I threw this together just to say, got it, you guys got this, you don't need charts. It makes sense to you, but in case you need charts, there's a chart. M protein, MGUS less than 3, smoldering, now transition, right? And then plasma cell myeloma, sure. Again, where are you here? And then, again, what's the key though, right? So, end organ damage when I've transitioned into multiple myeloma. The other 2 stages, I don't see any end organ damage. More of the same, I think you guys have got all that. Alright, summary. Yeah, asymptomatic, generally in the smoldering phase, they might start to show some anemia. Plasma cell, definitely symptomatic. Treatment, systemic therapy, we talked about some chemo, and then some supportive care. Key testing, electrophoresis, bone marrow, imaging, yep. And the second I think that this patient has this, whether they're in the MGUS phase or the multiple myeloma phase, they're seeing somebody. Right? Somebody with a hematology, oncology, something behind their name. Any questions on any of that? Pretty straightforward? Sure, that's what you say now until I give you the test and you're like, oh, you deserve to be that. Somebody recording this? Yes? Okay, so I can play it back and say I told you. Rick?
For smoldering, if it's asymptomatic, they're just driving, and they're not going to be dosing negative for proteinuria.
Yeah, so it's, it's difficult, right? And a lot of times, again, it's where did I catch this patient? Where did this patient present to me? So if I got my chem panel and his proteinuria is elevated, excuse me, serum protein is going to be elevated, right? And that's the thing, right? And this is why I say always look at labs in comparison to other labs. Right? Is this a guy whose protein's been kind of trucking along all along, and I see this slow elevation? Right? So always question the labs, and it's nice when you have something to compare it to. When I just got one snapshot in time, it's hard. Is this dude's baseline? Has he ever had a workup for it before? Right? 'Cause you're gonna get these patients where you're gonna like, how come nobody ever worked this up before? Right? And now you have to decide, are you gonna be like everybody else? Right? And you're gonna see with your thalassemia patients, right? Because somebody's gonna think that they had iron deficiency anemia, didn't do the whole 9 yards, and they'll be giving this poor patient iron, right? And now you're gonna inherit this patient. You're like, why are their iron levels still so deep? Right? Why are they still anemic? Maybe I need to go get what test? Hemoglobin electrophoresis? You guys already dumped that, holy crap. Right? But again, so this is the thing with what we do, right? There's no cookie cutter answers. Sometimes it's just that, hey, something ain't quite right. Am I gonna leave it alone? Am I gonna say something about it? This guy jumped out of his car 1 mile from the finish line. Right? Somebody in the audience said, wait, there's something not right. Or are you just gonna like give this guy the trophy for being the best runner? Any boxing fans? Roy Jones Jr., does that name ring a bell to anybody in this room? Nobody. Holy God, I got one now. Alright, so Roy Jones Jr. is a pretty good boxer. This isn't back in the Olympic days. So this is Seoul, Korea, 1988 Olympics. So this fight was so one-sided. Alright, so he knocked this dude down twice. And then at one point, the referee had to give this guy a warning for not protecting himself. That's how one-sided. Dude, you need to fight back. Right? Like, this is literally the conversation the referee has with the dude. So it ended up going to the judges, and like 3 of the 5 judges said this dude wins. And the whole audience was like, ooh. Right? The crowd went crazy, right? Because everybody's like, what the hell just happened? Did these judges not see what we saw? And then a couple of days later, it came out that like the South Korean contingency had like wined and dined all the judges the night before. Right? When something doesn't look right, there's a reason. Right? You can ignore it or you can investigate it. Hopefully you guys make the right decision. But nobody's gonna be looking over your shoulder a lot of the time, right? It's an integrity check. But, yeah. All right, any questions? So we got 1 lecture left, which is a